Nice to see many of you on this continent. I feel like many of you I saw recently at what we call Gokar in Vietnam, and that's probably the last time we were all together. So I'm going to provide an update on CARES, specifically about initiatives that I'm involved with in the quality improvement realm. And I'll give a little bit more insight into the other pillars of the CAROS grant that we're working on. So, and yeah, just to reiterate, normally with the CAROS meeting, there is a bar, but I guess we couldn't ask for a bar at 7 in the morning. I don't see a problem with that, but you know. I'm just, what did I do? Yeah, so I've been on faculty at Emory University since 2018, and Brian, it's a great story. You know, you want me to tell you over beers sometime, I will, but Brian actually recruited me to Emory, and it was a great experience, but I'm happy to be here now, almost 7 years later.
On Valentine's Day.
On Valentine's Day, yeah. And happy to be here 7 years later and still now involved officially with the CARES program. So next slide. Before, progressing on, I have to talk a little, I have to tell a bit of a story. And this is about the CAROL Act. Many of you may be familiar with how we are now funded through the CDC, but the CAROL Act started out of Kentucky with Congressman Barr. Unfortunately, pictured there, his wife Carol on the right died suddenly, unexpectedly from out-of-hospital cardiac arrest, sudden cardiac death. Ultimately, the cause was thought to be valvular disease that was undiagnosed. But Congressman Barr, as a result in action, came and put together an act called the CAROL Act that was designed to fund cardiac arrest research. And what happened was this was a bipartisan, unanimously supported act out of Congress in the United States Congress. Which, when's the last time that happened? Long time ago. So to see both sides of the aisle standing up and saying we really need this is really a testament to the importance of what's happening and what we're doing. Next slide. Sorry, so you can go back to that. I'm advancing, too quickly by pointing at you. The current participant map, we still have 13 states that are not participating in CARES as a CARES state, which is basically coordinated and operated at the state level, usually in coordination with the Department of Public Health or similar entity. Every state has a little bit different flavor with how it's run. Our goal and one of our missions and one of the 4 pillars of the CAROL Act grant is to get the remaining 13 states on board. It's kind of ironic, first there were 13, now there are 13. So we're going to push forward and get them on board. And a lot of our collaboration at this conference, we are taking large steps and efforts to move in that direction. If anybody's going to be at the state chapter meetings for any of the unhighlighted states, please let me know, because we're going to be running from chapter meeting to chapter meeting, trying to get in there and get a few minutes to talk about CARES. Next slide. Our next pillar is quality improvement, and this is my realm. This is where I spend most of my days. Talking about measuring, improving, and repeat. So measure, improve, repeat is a mantra that many of us are all familiar with, and we do in our day-to-day quality improvement efforts. When it comes to CARES and quality improvement, we are leaning on this cycle to really rally our partners and external collaborators to come together and share that singular message. Using the CARES data registry to identify areas and opportunities for improvement, we can engage external partners, which I'll talk more about, and come to these what we call priority sites and say, hey, we've identified areas in your region that we can really work together to enhance quality assurance, quality improvement in cardiac arrest. Next slide. It's all about this equation. I always say, if you're going to remember anything from this talk, I'd say from the whole day or the whole conference, it's this equation, right? If we want to make a difference in out-of-hospital cardiac arrest, we have to be focused on T, B, and HPCPR. Telephone, bystander, and high performance CPR. That's the equation that we are targeting to really make an impact and increase bystander compliance, reduce the timeliness or enhance the timeliness to first impression, reduce the amount of time it takes to start pushing on somebody's chest. And of course, with that, we hope and expect to see associated higher survival outcomes. I haven't memorized a lot of equations in my life. I know one is like the quadratic equation, x equals minus b plus or minus the square root of b squared minus 4ac all over 2a. Everybody else remember that still? And then this one, that's it. I only got 2 in there. So this one I think is a little bit more important and impactful. Next slide. So I mentioned briefly our partner organizations. These different organizations all represent a different pillar or a leg of the table on the quality improvement effort for the PAROS Act. And I'll talk about each individually. CARES actually started at Emory and maintains collaboration and is supported through Emory University as the primary institution on the grant. Now the Emory University Winship Health Sciences Center is primarily where the grant is held. We still collaborate with the CDC since the PAROS Act is now basically funded through the CDC. That's the funding mechanism for the PAROS Act grant. So we have regular meetings and check-in calls, every couple of weeks, just to make sure we're keeping up with the main objectives of the grant. As the CDC is targeting, new efforts with the new administration, we stay close in contact with them and make sure we're aligning with the core beliefs and idea and hopes and expectations for the PAROS. The other organizations mentioned here have been moving in a very similar direction and have been talking for many years. I know Brian's been involved in conversations with a Resuscitation Academy, CPR Lifelinks, Heart Association, and Red Cross separately and sometimes together and on and off for the last several years. Now we actually have everybody in these organizations, we have a seat at the table and we are working together. We actually have a strike team that meets every couple of weeks and we align our efforts, we share our objectives and key results. We work together to target different areas around the country to focus our quality improvement efforts. Next slide. So, you may have heard of the 10 steps to improve out-of-hospital cardiac arrest. I think at this meeting they're on the screen in some form or another, in every presentation. The Resuscitation Academy really pushes the 10 steps as a mechanism for agencies, regions, municipalities to enhance their out-of-hospital cardiac arrest program and really move the needle and measure and improve in the right direction. So I'll point out at the end of the presentation again, how each step is kind of owned by one of our partner organizations. Next slide. So Resuscitation Academy first, go on. We identify Resuscitation Academy as the leader in high performance CPR. Anybody who's participated in an RA, foreign and domestic, anywhere in the world, we see them as part of the Global Resuscitation Alliance. We have, upcoming, I think EMS Asia, we're going to have one this year, right? So, I think that there are plenty of opportunities internationally to participate in one. I was involved at an arm's length. I think my first RA was actually in Tokyo. And admittedly, I didn't really know what was going on. I could see, though, exactly what was being instructed with high performance CPR, and that message was very clearly translated. I got to see one in English, so it was a lot easier for me to understand last fall, and it was really, I would say, a collaborative effort between the agency, leaders of the agency, and in emergency medical dispatch, in quality improvement and quality assurance, and often, fire chiefs and leaders who may not be plugged in to quality improvement efforts on the medical side as much as frequently, were really, eyes were open. We marched through the 10 steps, got behind the science behind high performance CPR. You know, what happens when you don't do compressions and you try to shock the heart? Well, you can see that on a video. It really makes a lasting impact on your impression of out of hospital cardiac arrest response, right? So we really, the RA gets into operationalizing the science, looking at, you know, individual skills and making sure we can push agencies to get to mastery level with a perfectly orchestrated, you know, cardiac arrest model, demonstrating, and then making others try it and show that they've really grasped the concept. So communication, team skills, building that culture of excellence. There are several mantras that we lean on in an RA, as you know, that we really just say, this is how you need to think, right? Measure, improve, repeat. There are things that we are doing to really change the culture of an agency. So next slide. And as you'll see here, as I described, working with agency leaders to give direct feedback from, you know, step one in the chain of survival all the way up to hospital arrival and beyond, but getting the agencies to participate and giving them direct feedback. And it's kind of the train the trainer approach. So those leaders go back to their agencies. They say, hey, I learned something great. We're going to teach everything that the RA taught here. The RA has resources that you can bring back to your agency, and it's an ongoing conversation and relationship. That's really the key. You know, that ongoing conversation is why and when we see the change. Next. This is just demonstrating how each one of those 10 steps, if we can impact it separately and get everybody performing to mastery level for things like rapid dispatch, turnout, you know, time at the patient side, starting compressions, immediately getting bystander CPR. TCPR is going to get people's hands on the chest a lot earlier. We are doing all these things to change the slope of death, right? And we want to get every system up to a high performing system by moving the needle on each one of those indicators. Next slide. CPR lifelinks, and we are lucky enough to have some of the subject matter experts, these subject matter experts for CPR lifelinks here today. So thanks guys for coming. CPR lifelinks is a telephone CPR focused education and quality assurance program that we can implement in programs. It's a national initiative, there we go, to unite EMS and 911 agencies and improve survival rates in their communities by implementing CPR. This I can speak to firsthand because our one of the agencies in DeKalb County, Atlanta, Georgia, where I am medical director, is actually a pilot site for the quality improvement initiatives at PAROS. You know, I guess it helps to be friends with the executive director of PAROS, and you know, yeah, maybe I don't know. But we had the data, we contribute to CARES, and we met all the metrics to be considered a priority site. And I'll talk a little bit more about that, but basically high social vulnerability index, you know, lower quartile of survival and bystander CPR. So those are areas that we've identified to improve. The telephone CPR training, we're gonna, you know, focus on recommendations and guidelines. We actually have telecommunicators practice CPR skills so they can see exactly what they are instructing folks to do over the phone. You know, really getting down to the nitty-gritty details, reiterating a lot of the science of CPR that we teach in the Resuscitation Academy. It's synchronized. You know, that same information is being shared to telecommunicators and 911 dispatchers. And recently, CPR Lifelinks has aligned with Resuscitation Academy, and we are targeting a train the trainer approach so that we can teach leaders within different agency dispatch centers. They can bring the concepts and teachings home, and we follow up with training with the entire center, trying to figure out ways to really scale that model and reach as many folks as possible. Next slide. So the instructors up front here usually lead traditionally would lead a 3-hour presentation and follow up with continuous quality improvement, evaluation, and giving feedback on how agencies are actually reviewing the cardiac arrest call. And, you know, using in many scenarios, using the CARES module for telephone CPR. But figuring out ways to enhance that process, it takes a lot of time listening to those tapes, right? So, so we are very motivated to figure out innovative ways to listen to tapes, to chronicle the timestamps within those cardiac arrest calls, and to get all that information in one spot. So constantly thinking about ways like maybe AI opportunities or machine learning and algorithms that we can use to enhance the quality assurance process and make it easier for agencies, especially priority sites that are going to be underfunded and may not have personnel and resources to be able to do this. So really, it's a great program, and it has been for DeKalb County. Next slide. Red Cross. So we're on to the third leg of the four external partner organizations. Red Cross is known for Mission CPR. This is a national effort to increase access to bystander CPR training. They are targeting underserved communities, which aligns with our fourth pillar to address disparities in out-of-hospital cardiac arrest. And in doing this, we have aligned our strike team of external quality improvement programs to say, okay, we are going to target this area and host a resuscitation academy and stimulate conversation about getting CPR lifelinks training. At the same time, Red Cross and Heart Association, which I'll talk about, can say, okay, we have regional representatives in this area who are very familiar with the interweavings of these agencies and who know where all of the bystander training is currently happening and where we need to focus efforts. So having those boots on the ground, those regional experts with each organization is a huge win, and really that's been the difference in most of the communities we've worked. Next. Heart Association, next slide. Heart Association recently came to create a nation of lifesavers. And they are using the chain of survival as a mechanism to educate the public and share, from the point of lay rescuers. I think I'm on track to finish a little early. I think the lay rescuer, EMS, and survivor designation owners of those parts of the chain of survival is a big part of their education and campaign. And so they're primarily focusing on this over the next few years, but identifying mechanisms to enhance bystander CPR training in schools, in communities. Within the United States, we see different regions are very heavy with Red Cross. Some are more heavy and infiltrated with Heart Association. So it helps to have both organizations with similar missions at the table, so we can work with them. All right, next slide. This represents community strategies that Nation of Lifesavers is doing to reduce disparities. They are very motivated to sustain AED registries, get lay responder alert systems. Heart Association is working to push telephone CPR in the agencies where they're already contracted. Really trying to get states on board with participation in CARES. Over the last few weeks, Heart Association has pushed out communication with state-specific goals for the next year. And at the top of that list, it says pushing participation in care. So they see, the value of participating in the registry. And like I've said many, many times, we can't improve without measuring, right? So Heart Association is pushing the same message. And it's great to have this synergy. We're all talking and moving in the right direction. Next slide. I already talked about the 10 steps, but this slide is really just to demonstrate each organization that we're working with is kind of owning and leading and really, I would say, representing a different step of the 10 steps here. At the bottom, striving for accountability and working towards a culture of excellence. Those are baked into everything we do, especially with the mantras and the alignment of missions between multiple organizations. We're really seeing all of us, sharing the same message. Next slide. Briefly, I'll mention the modernized software platform. This is the third pillar that I'm admittedly not very involved in. Monica's leading that initiative up here up front. The goal is to modernize the online platform with continuous updates and collaboration with partners. It's designed to be a seamless transition of data, so it can be easily represented in a functional dashboard. These are mechanisms that we're doing to really modernize it. Synergy between the development team and the data science team within CARES has really moved this in the right direction. So the health disparities pillar is the last pillar, and this infiltrates everything that we're doing. All these initiatives, all the quality improvement, strike team initiatives that we have, everything that we're doing in building our dashboard, disparities at the top of the list, and it's our why, right? It's our mission. This is what kind of drives our decision making. I mentioned briefly already, but we've identified priority sites or underserved communities based on historical CARES outcome data, based on the CDC Social Vulnerability Index, which has about, I think that index is made up of like 16 different sub indices that are multiplied together to give us a measure of the need in certain areas. And finally, this is big, right? We can easily walk up to a priority community and say, we're here to help you. We are going to save your cardiac arrest outcomes and make it better, right? That never works. We try to engage external stakeholders in priority communities early on, so that as we're starting to build these programs and work with these regions, they have a seat at the table and they are contributing to decision making and planning to get these organizations moving in the same direction regionally in their area. That doesn't work if the leaders and the agencies that we're targeting are not willing and able to participate. So we get told no a lot, and we say that's fine. We'll keep in touch, and we keep checking in. And sometimes the stars align, leadership changes, whatever happens, and they say, okay, we're ready to go. We are new, we are different. Let's do this now. So next slide. Last is just a few slides about mapping and analysis. I have to share the Chicago bystander CPR rate map because this tells a story. They've allowed us to share this, and we often will give this as an example to agencies and say, this is what you can do to show your improvement over a time period. This speaks to everybody. You can share this map to non-medical, fire chiefs and county managers and say, this is why we need to participate in CARES, and this is why these organizations working with CARES are going to come in and help just beef up the quality improvement initiative. Next slide. We are graciously allowed to share the Honolulu and the Hawaii experience. So this is the static map that we've been sharing with representing bystander CPR rates as an example here. We also have maps like this for AED utilization. Next slide. We are in the process of moving more towards an interactive map so that agencies will be able to see all of their data and look at it, click on it and see different areas of the county or the state that they are seeing on their dashboard to focus their efforts. So this kind of represents, California versus the national data. You can see the comparison for benchmark purposes. And then next slide. And this is where it gets really cool. You're going to push play on this, so it's actually a video. So Manchi, many of y'all may have met her, is our geospatial analyst. She is, we call her a magician, I think, but she's done wonders to create these interactive maps where you can actually put your county up and just click and identify areas that you want to target, and you can drag and compare, seeing all the maps of bystander AED utilization, SBI, bystander, CPR compliance, and then finally out of hospital incidents. Seeing that all in one spot and being able to work and move through your maps I mean, that's what everybody wants. People have been asking that for years, and now, man is delivered, so, good find. So yeah, this is really new, this is something that we're excited to share, but this is the next step for us. And I think that's my last slide. I just wanted to share those examples, and those are my updates at CARES. I'm happy to provide any answers to questions you may have.
So I have a question. So I see that the American Heart has the learning and the AD registry and the layperson, but I don't see a partner out there. So are you part, is that most point, is it Good Sam, who is the partner?
Every community is different. It's really up to the community, you know, that's their roadmap. That's their presentation for since the Hamlin, that's the program that's coming up, right? This idea of heart safe nation. And you know, both the nice news, as Mike said, is we're working with both the two largest training organizations in the country, right? Heart Association and Red Cross. We're on the same calls with them. We're using a data-driven approach, you know, so we have a CARES community. We're like, hey, here's your county level data. Would you like to get on a call, you know, when we can get everybody aligned? And then really it's national folks saying, hey, San Diego would be a great example, which is Revive and Survive program. We learned about this a couple months ago. Got on a phone call. They're telling us, yep, our goal is to train 1 million people in this county in CPR. Like, wow, that's very ambitious. How's it going? We've already trained 330,000 in a year into it, right? We're like, wow, that's great. How is that working? So the national folks are learning from their folks on the ground, both Heart Association and Red Cross. So those are the types of conversations we've been having. They each kind of have a different strategy, I guess, but the idea is that we're trying to work with communities with a different approach to say which neighborhoods in the county is by CMC the lowest. So we can map that. You know, are there resources that both organizations can put? But it's really up to them. You know, the idea is that they're providing free training. It's not a 4-hour course, hour depression only, where the need is the greatest. So that there'll be more conversations that we'll probably be sharing with the community next year, but the concept is trying to work collaboratively, you know, with sites, use data, and then CPR lifelinks, you know, is there a community we can work with? Do they qualify? Is there interest? Question, Kevin.
Oh, I just wanted to make a comment. I do think it does come down to the community. Certainly in Maryland, we've been doing RAs for 12 years, focusing high performance CPR, and I believe that looking at our data, we know that just what Michael said, that telephone CPR and bystander CPR is the next important thing. So we've focused through the RA with CPR lifelinks and had telephone CPR training for 20 of our 24 911 centers. And the idea is that the telephone CPR can synergize with bystanders, and we get CPR before EMS arrives. In some of our communities, we only get a minority of the ambulances get there within 10 minutes. So we need those things. So I think it really is the important synergy, and I appreciate everything that you're all doing.
I'm just about to say you have come a long way. This is really great. What you've done with getting the other organizations together. That's a big deal.
We appreciate that. It's been clearly a team effort, and the partners, right? It's been a team approach, and you know, the idea that there's congressional appropriation, you know, we always knew would need to happen to be able to get that level of support from CDC. So we're hoping to build upon that, you know, and acknowledge like there's a lot more that can happen. Let's use these resources to work at a local level, at a state level, and regionally, and continue to have dialogue with these partner organizations. So super important. Thank you. We're gonna shift gears and let Marcus introduce. Thank you.
So our next speaker is Dr. Gayatri Nadarajan. She is a consultant emergency physician in Singapore General Hospital, and she's also been leading our PAROS team efforts on developing a tool to actually help do a systems assessment, especially for low middle income countries, and we call this the PACSET, Pre-Hospital Emergency Care Systems Evaluation Tool. She's also going to give us a quick update of what's happening in Asia with PAROS and some of the other initiatives. So, Kaya, over to you.
Sorry, yeah.
You did that 2.5 years ago. What's going on? You just came from Asia?
Yeah.
Right, so good morning, everyone, and thank you for giving me the opportunity to update about PAROS. So the PAROS, the ethos and the values are a lot like CAS. So I'm glad that I'm going speaking second, but it's covered most of the background behind how PAROS and CAS function. Okay. So since its conceptualization, 2010, we've regularly had new countries, new sites from different countries joining the Pan-Asian Resuscitation Outcome Study Network. And currently, these are all the different countries and sites that are involved in PAROS. So as you can see, we have quite a few of the countries of Asia. But within that, you will see that some of the countries that are missing, like Laos, Cambodia, Bangladesh, are the countries that actually still struggle with the EMS development. So unlike the US, so Asia there are many countries, right? And all the different countries are at different stages of development. The EMS system is, some are really advanced, and in some places it's still unfortunately seen as a transport service. And things like having a defibrillator on the ambulance or getting the public to perform CPR is still a struggle in many of these countries. And in countries like Laos, Myanmar, Cambodia, and Bangladesh, emergency medicine itself is struggling to be recognized as a specialty. So, hence, it's been, even though we do engage with them, I really put it on the PAROS. So, within PAROS, we have a process where we actually get the sites to submit any proposal that they would want to study the cardiac arrest within their region. And every year, like a few of the studies will get approved. So this is an example of a study in Thailand. And another study in China. Right, so and these are some of the publications that we've had so far from PAROS. And similarly to CAS, we are starting to look a lot more at the socioeconomic factors that actually affect bystander CPR or cardiac arrest outcomes in different areas. But as you can see, because of the heterogeneity of the development of the EMS system, the different countries will choose which quality improvement project they want to focus on and actually work on those. So with similar to CAS, we work very closely with the Resuscitation Academy and the Global Resuscitation Alliance and have been trying our best to promote the 10 steps amongst the Asian countries. So we've got a grant to actually got a grant to recruit the different sites within Asia to actually work on which areas of the 10 steps that they would want to focus on. So if you look at this slide, the 1 to 10 represents the different 10, the GRA 10 steps, and the different countries have actually stated, whether it's been implemented or not, and they get to choose which of the 10 steps they would like to focus their system on, and then they would work on it as a QI project. So, for example, if we look at Indonesia, they've chosen to actually work on a more systemic project, a bigger thing like developing a paramedicine program for the nurses in these parts of Indonesia. So one of the one of the areas of, that we have, many of the countries have decided to focus on was to develop, their dispatch assisted CPR. So, we actually approached, Singapore and, you know, to get some advice on like the training packages. And what we have developed in Singapore is a dispatch, training program, which we managed to, help with training the some of our other Asian partners and get them to implement it within their systems itself. And then we actually you know, did a comparison study to see the high-risk outcomes between the sites that have implemented dispatches with CPR and the sites not implemented. So the another project from the you know, based on this GRA 10 steps. So in Bangkok, for example, they have decided to focus on two things. One is layperson CPR training, and second is to develop a program of first responders and they've selected the motorcycle taxi drivers to actually help to be the first responders. So as we know, so in Thailand, in Bangkok, the road traffic, the traffic can be pretty crazy, right? And that's a huge barrier for the ambulance to actually arrive, you know, arrive in a timely manner to the patient's site. And not only that, but I mean, many of the roads, they are really narrow, and which makes it hard for the ambulances to go through. So what they have done is to actually develop, so they recruited a bunch of taxi drivers, but they actually ride, it's a motorbike taxi, and then you know, got buy-in from them to actually be the first responders and to actually be able to carry the AEDs on their motorbike taxis, and you know, provided the training, right? And they also use the they work with the Thai Red Cross to develop to smart technology, right? And right. And then they found that the bystander CPR rate has improved you know, since its implementation as well as its AED use. It's very promising to look at. Right, and moving on to Singapore, right? So that goes from, right? So in Singapore, we have had good progress with our bystander CPR rates, outcomes. Two things that we have noticed. First was I think just like everywhere else during COVID, there was a big drop in the bystander CPR rate. Second is we noticed that there is we're reaching a ceiling in terms of the bystander CPR rates. So we're currently trying to look into what are the barriers for bystanders to perform CPR. One of the differences I've noticed is there has been a difference in the bystander CPR rates for females experiencing cardiac arrest in Singapore, Japan, and Korea. And so we're currently conducting a study with Singapore, Malaysia, and Vietnam to actually understand the barriers to perform bystander CPR for females with cardiac arrest. Right, so now currently we are working on this program called FISCA, so Future Leading Interventions for Survival After Cardiac Arrest. So this FISCA has so it has 4 themes. So firstly, we are actually working on our cardiac arrest registry. So besides just you know, having what we normally have, we are focusing on developing quality of life data within our cardiac arrest registry in Singapore. That's theme 1. Second, we also you know, trying to enhance our community response, and then for theme 3, to enhance the ambulance response, and the last theme is to actually develop it within to improve cardiac arrest outcomes and survival in the Asian continent. So for theme one, we actually have we are actually conducting a multi-center cardiac arrest survivorship study. So we call it POLYCAS. And up till now we have 69 survivors and 39 caregivers have been included across the 7 hospitals in Singapore. Right? So in theme 2, we are looking at the bystander CPR, but we are looking at the quality of the bystander CPR. So what we have been doing is that we have been using the CPR card to actually record the quality of CPR being given by bystanders. And we also have actually developed this app which allows the dispatch to witness what the bystander is doing when they're performing CPR, so that real-time feedback and coaching can be provided as the bystanders do CPR on the patients. So this is currently ongoing. The last and theme 3 is focus on looking at targeted temperature management using cooling vests. So to actually optimize the management of cardiac arrest patients in the ambulance itself. So rather than starting the cooling at hospital itself, to actually initiate that in the ambulance itself. And the last one, which Dr. Marcus was talking about, is actually so it's a global health approach. So like I mentioned earlier, that one of the issues that we face in Asia is that they are all at different stages of development, and many of the quality indicators that are present internationally, which have been developed mainly by the Western more developed systems, are not really suitable for the many of the systems in Asia itself. So what we've embarked on doing is to develop a set of indicators that can be used by the developing countries in Asia, and that project is called PACSET. And we actually co-developed the indicators by involving the stakeholders in developing them. So we did it in 2 big stages. The first one involved a Delphi style meeting. We got everyone in the room and voted on what is your priority and what is not. And the second meeting, we used a nominal group technique to actually zoom in on the priority areas that we want to focus on and develop indicators for those areas. So we're currently in the process of fine-tuning that. But we have been actually implementing this toolkit when we actually conduct Resuscitation Academy in the different countries within Asia. And this toolkit actually it complements what WHO has been developing. So they are also developing a pre-hospital toolkit, but they have not released it yet. It's, we have been in discussion with them, and we realized that both of ours complement each other rather than replicate. So these are some of the publications for this. In front, Dr. Anshul is there. So we've been working on this couple of years. And like what I mentioned about Resuscitation Academy, so we have been, over the past 2 years, we have conducted Resuscitation Academy in over 7 Asian countries. And during the process, we also get them to, we encourage them to actually contribute more to the PAROS data, and at the same time, try out the PACSET tool, and encourage them to take on, to spread the mantra of Resuscitation Academy, and to actually encourage them to conduct it in other parts of their own country. So we're spreading the whole RA, in Asia. Right, and, so upcoming, for future research collaboration, now we are planning to actually look at the, future burden of cardiac arrest, but not just using the PAROS data set, but also looking at using the publicly available, data on the, population factors as well as the aging trends, and to actually model what cardiac arrest, load will look like in the future. So this is what we can do, and there is any interest, next slide. You know, if there's any interest from any of you all, please do approach, Dr. Marcus. This, yeah. Yeah, and this would be the data that we plan to, use to actually work on this modeling. Okay, and lastly, we've also been updating the exam template. So, this one for you guys, just about the on that. Thank you.
Don't be shy, questions.
And maybe I can just add a few comments about the global burden of cardiac arrest study. So the idea is that this is under the Lancet Commission for Sudden Cardiac Death. And what we want to do is basically use available data that is already in the CARES registry, for example, in the PAROS registry, link that with publicly available demographic and population based data. And then you can actually make projections using the global burden of disease kind of methodology and look at what we expect in the next 5 years, 10 years, 50 years in terms of cardiac arrest burden in the different regions of the world or the different countries. You know, so what we do need will be a local kind of champions who are willing to work with us, and then, for example, use North American data and feed that into the modeling, and then we will combine that with data from Asia, Europe, Africa, Latin America.
Yeah, I just wanted to ask, is there an early sense in PAROS how well the dispatcher video consultations are working in out-of-hospital cardiac arrest?
As in,
Is there a general sense of how well that's working, like
In Singapore.
in Singapore? Yes. You know, they have a video program in San Antonio, and you know, I think there's a lot of promise in that. I imagine also a lot of complications in the actual implementation of it. So just wondering if there's any early impression on maybe what some of the barriers are in those video consults.
Yeah, so I think that, so just like when we're actually monitoring the videos and quality. So from the very beginning, there were lots of, okay, so in Singapore, firstly is multi-ethnic society, and they speak even though there's like English is our main language, but many of our citizens speak either Malay, Chinese, or English. Within Chinese, there are different dialects. One of the big issues was the language issue, and then that's the one. And the second layer was even the nuances about like pushing harder and the different instructions that were given to them, because understanding would be different from what they expect from them. And there were the barriers.
I can help with that question, Michael. So in Singapore, we have done a kind of video dispatch trial over the last 2 years. And the technology is quite simple. Basically, 995, our crew of 911, will be able to actually send you an SMS link. So if you are the bystander that's falling, we just send you an SMS link. And if you click that, it actually takes over your phone, activates the camera and the audio, and you can actually start talking to the dispatcher, right? And the challenge has been actually finding the use case for this. So initially, there was some thought about, could we use this in a cardiac arrest, But the challenge is that we found that it actually delays the onset of CPR. So the way we use it now in Singapore is that we use this for unconscious patients where the caller is not certain whether the patient is actually breathing or not. right? So, the no-go, right? So is the patient conscious? I don't know, I'm not sure, Are they breathing normally? I don't know, maybe not, right? Okay, click on the link, ma'am. Point the camera to the victim and let me see whether the patient is breathing or not, right? And then based on that, we found that we actually increased the recognition of cardiac arrest by about 20%, 20 to 30%. And in those cases, we were able to start CPR instructions. Whereas in the past, they may have not received CPR. So for us, that has been the use case, right? But we do not use it if it's a confirmed cardiac arrest. If it's no, just go. And there's no video involved, just tell them to pump on the chest. The other people who can answer this question, I think, are my Korean colleagues who are here. And they have done quite a bit of work with video dispatch as well, right? So I don't know whether Dr. Song or anybody want to ask.
Actually, where we use the video CPR in our dispatchers, it's not the same method in Singapore. We don't use the SMS because the dispatcher caller can know the telephone number who the calling to the dispatchers, so they can call back with the video call. Then the caller can receive the video call, and we can communicate with the video. So, but I agree with Marcus about the delay with the use, especially the older people cannot easily convert to video from audio. So we are trying to make that more simple, and then the show that kind of gaps. But we don't have the main rule about the video call.
When the camera is activated, is it oriented in the right direction automatically? Or does the user have to reorient the camera? Because I still don't.
So for our technology, the dispatcher can control whether you are using the front camera or the back camera, basically, right? Yeah. So that is so far not a big issue.
Just an observation, I think that over decades, we've learned that letter perfect CPR is what makes high performance CPR. And I think this is a process, and it's a process improvement, time improvement, because right now our dispatchers have only audio. And even the best practice of saying turn on your speaker so you can hear us while you do CPR is not what we can limit to. But I think if we could get the video and could say, press faster, press deeper, let up more, things like that, I think letter perfect CPR still helps the patients, even though if I say that there's no way to do it. I think that there are options there that might be different.
So maybe to respond to Kevin, how we're thinking about this at the moment is that we are actually deploying this as a bundle with the CPR card linked to the phone app. So the version 2.0 of CPR card that we're doing now has a Bluetooth function. And the CPR card is only used by our My Responders. So in other words, it is not the caller who is doing bystander CPR, but it is the volunteer who is activated and within 400 meters. So it's a second person on scene that's coming, bringing the CPR card. And this has a built-in accelerometer that actually can give you feedback on rate, depth, and all that. And then now it links with the phone, the My Responders phone. So it turns on the video and the audio as well, and has a meter as you do your compressions on the card. So you can see the rate depth, pauses. And the dispatcher at the other end of the line can also see the rate depth pauses. And the dispatcher can also see on video the volunteer and the victim. And so then the idea is to have a three-way link where there's a kind of real-time feedback, real-time coaching. And the holy grail is, can we improve the quality of bystander CPR, right? So we have a plan to equip 15,000 volunteers with the CPR card. We are now at about 1,000. We have had about 10 live users of the card, and the video and the technology is working fine, right? So the first question we were asking is, technically, is it feasible? Because there are many hoops to jump through. The answer is yes, it's feasible, it can be done, my volunteers are doing it now in the field, right? And I think it'd be quite fascinating to start to look at the actual CPR quality data. So that is where, you know, hopefully in a few months, we'll have some data that we can share.
Very good.
As you look at disease burden, the arrest burden, you're talking about the aging population. Have you been able to correlate that to the age of the people that are arresting increasing?
So we look at that in Singapore, looking at the trends between the aging population and it has been increasing.
Okay.
Yeah. We've published a lot of paper and elections. We started to fantastic.
Questions? Okay. Well, thank both the speakers, great for the questions and class dismissed.